Inflammation. It's a word we hear all the time, isn't it? But in medicine, it's one of the most fundamental processes in the entire body. You can think of it as our primary defense system, our biological first responder. But, as we're about to see, this incredibly powerful protective force is a true double-edged sword. It's capable of both amazing healing and causing immense harm. So let me ask you a question to get us started. What do a simple paper cut, a really serious bacterial infection, and a chronic autoimmune disease like rheumatoid arthritis all have in common? I mean, they seem totally different, right? Well, the answer is inflammation. It is the one single biological process that connects all of them. It's just playing out on different timelines and with very different consequences. Okay, so here's our game plan for this explainer. First, we're going to frame inflammation as the body's alarm system. Then, we'll break down the two main types, the fast and furious acute response, and then the slow, grinding chronic siege. And, to finish up, we'll look at the aftermath, how the body cleans up the mess and repairs the damage. So let's get right into the single most important distinction in this entire topic, the difference between acute and chronic inflammation. Look, understanding this isn't just some minor detail. It is the absolute foundation for figuring out how countless diseases actually work. These are two fundamentally different paths the body can take.
This table lays out the core differences perfectly. Let's just walk through it. Take a look at the onset. Acute is explosive. We're talking minutes to hours. Chronic, by contrast, is a slow burn. It can take days to get going. Now, check out the cellular infiltrate. In an acute response, the first ones on the scene are almost always neutrophils, but in a chronic fight, the body calls in the heavy hitters, macrophages and lymphocytes. This difference in cells is so important, and it leads right to the tissue injury row. You'll see that acute damage is often pretty mild, while chronic inflammation, well, that can be severe and progressive. So let's focus on that first type. I want you to think of acute inflammation as the body's SWAT team. It's the emergency first responders. The second the alarm sounds, they are on the scene and they act fast. Let's make this real with a clinical case. So we have a 22-year-old woman. She's nursing and she develops a classic breast abscess. All the key signs are there. It's tender, it's erythematous, which just means red, and it's draining this thick yellow fluid. Now that fluid, that's a major clue. So if we were to put that yellow fluid under a microscope, what would we see? Well, the answer is a massive, massive number of neutrophils. That fluid is pus, and pus is basically just a soup of dead and dying neutrophils that have done their job fighting bacteria. This is the absolute #1 hallmark of acute inflammation. And that brings us right to our formal definition. Acute inflammation is a rapid response designed to get two key things to the site of injury: leukocytes, specifically neutrophils, and plasma proteins to help fight whatever the invader is. Speed and neutrophils. That's the crucial takeaway. But what happens when this response is too strong? How do we, as clinicians, intervene? Well, one of our most powerful tools is corticosteroids. But how do they actually work? They're incredibly effective because they block a key enzyme right at the very start of the inflammatory cascade, an enzyme called phospholipase A2. And this diagram shows us exactly why that's so powerful. Just follow the pathway from the top. When a cell membrane gets damaged, phospholipase A2 gets to work converting parts of that membrane into arachidonic acid. I want you to think of arachidonic acid as the raw fuel for the entire inflammatory fire. As you can see, it feeds into two subpathways. Now, look where corticosteroids step in. They put up a shield, blocking phospholipase A2 right at the source. This is why they're so potent. Unlike something like aspirin, which only blocks the COX enzymes further down one branch, steroids cut the fuel line to the entire system. Let's look at another classic case. A 16-year-old boy comes in with severe right lower quadrant abdominal pain. He's got a fever, and his white blood cell count is through the roof, specifically with a high percentage of neutrophils. This is just screaming acute inflammation. It's a textbook appendicitis.
So when the surgeon opens him up, what are they expecting to see? Well, based on our last case, we can probably predict it. They're going to find congestion, swelling, and that same purulent inflammation, the formation of pus, just like we saw in the breast abscess.
Purulent inflammation is just one way the body can respond. This table shows us the main patterns. For instance, the fluid in a simple blister, that's serous inflammation. It's mostly cell pore fluid. Sometimes you get a sticky fibrinous type, but for our appendicitis case, we're focused on that highlighted row, suppurative or purulent.
which is defined by tissue death, necrosis, and that classic accumulation of pus we've been talking so much about. Now let's switch gears completely. If acute inflammation is a rapid raid, chronic inflammation is a long drawn-out siege. It's a totally different kind of war, with different soldiers and different strategies. Our case here involves a 37-year-old man with AIDS who's been sick for weeks. The key here is the time frame, 3 weeks. This is no longer an acute problem. This tells us the body has been fighting a persistent battle, likely against some opportunistic infection that his immune system just can't clear. When we look at his lung biopsy, we see these bizarre, huge cells with multiple nuclei. What in the world are they? Well, these are the calling card of a special type of chronic inflammation, and they are derived from macrophages. The long-term battle has actually caused the macrophages, the main cells of chronic inflammation, to change and fuse together. This specific pattern is called granulomatosis inflammation, and it really represents a change in tactics. When the body realizes it just can't eliminate an invader, like the bacteria that caused tuberculosis, it switches from attack to containment. Activated macrophages surround the enemy. They fuse together, and they recruit other cells to build a tiny fortress, a granuloma, to wall off the threat. And these images show the process perfectly. On the left, you see the building block, a multinucleated giant cell, which is literally just a bunch of macrophages that have fused into one. Then on the right, you see the finished structure, the full granuloma, with a collection of these cells and lymphocytes forming a perimeter, trying to wall off the problem area. So after the battle, whether it was that quick raid or the long siege, the body has to clean up the mess and rebuild. This is the process of tissue repair, which can lead to perfect healing, or sometimes it can lead to scars. And the absolute foundation of this repair process is something called granulation tissue. Now, this is not the same as a granuloma. Granulation tissue is that pink, soft, granular-looking stuff you see in a healing wound. It's made of 2 critical things: new, leaky blood vessels to bring in supplies, and fibroblasts, which are the cells that are going to lay down collagen to build the scar. And this is what it looks like under the microscope. Yeah, it's a busy, kind of messy-looking scene, but it's incredibly organized. You can see all the new small blood vessels, the spindly little fibroblasts starting to work, and a few scattered inflammatory cells still doing cleanup. This is the picture of active healing. But sometimes this repair process goes into overdrive and you get excessive scarring. This slide shows 2 key types you really need to know. On the left, a hypertrophic scar. This is where the body makes too much collagen, but, and this is the key part, it stays within the boundaries of the original wound. It's raised, but it's contained. On the right, though, you have a keloid. This is a whole different level of overgrowth. The scar tissue actually invades the surrounding normal skin, growing far beyond the wound's original borders, and it won't regress on its own. Which brings us right back to where we started. This quote perfectly captures the dual nature of inflammation. It is absolutely essential for our survival. Without it, simple infections would run rampant. But when it's dysregulated, it becomes the very driving force behind so many of our most challenging chronic diseases. And that leaves us with a final thought. We've seen how powerful our anti-inflammatory drugs can be. But inflammation isn't the disease, right? It's the alarm bell telling us that something is wrong. So as we get better and better at silencing that alarm, we have to ask ourselves, what's the danger of turning off the very warning system our body relies on to survive?